Waiting for Dr. Coel, I've been trying to see if any of our participants have any interesting back pain patient stories to tell. But then I mentioned it's also not much your specialty. So,
well, what I can tell you is lately we have seen a few cases of, I guess, lower back hip pain who ended up being sort of myositis around the hip area, and osteomyelitis, which is an unusual location. Our best bet is that children, and these are all very active children, so these are very active children. They jump in all over the place, they pull something, get a little bleed in the area, hematoma. It doesn't have to be big, and then if they have a bacteremia, then it gets all infected. So yeah, those kids, and they can present very subtly. I mean, just not wanting to walk too much, but not with very well localized pain, and well, you end up needing imaging to sort that out. So be on the outlook for unusual cases. If they don't resolve quickly, or if they have labs that are abnormal, high inflammatory markers, well, there may be something else going on in that hip, and you need to image. So yeah, we've seen quite a few of those lately, and for some reason, I don't know what. After COVID, everything is just unusual.
that is actually a very good point that you bring that up, because that's true. We have been seeing so much like sacroiliitis and just such interesting areas for inflammation and deeper seated infections that are coming in, yeah, with really quite insidious onsets and very vague, non-specific symptoms often. And I find some have high inflammatory markers, but really not necessarily all of them by any means.
And they're not little babies. Like sometimes you see hip infection, 2 3 year old, and those are more classical. But this kid's 5 7 6 years present in a more indolent way, and again, takes a few times before someone decides to do an MRI because they don't look that sick. And you're right, yeah, the labs don't look that horrible that you're going to jump into doing an imaging right away. But at some point you do, and then all of a sudden it's like, look at that, there is something going on there. So the kid was not lying. A couple of them have been called like, yeah, you're really having something. It's like, yeah, they are. They do have something.
Yeah, and it really is sometimes so hard to tell because they really do necessarily not seem that ill even on exam. That's a very good point. We haven't been treating them too long though as an inpatient, as far as I remember. Is that right?
Well, someone said something.
No, I think that was just background.
Well, if they have regular MSSA, non-MRSA, and if they don't need much drainage, then yeah, a short course sometimes is all that you need. Well, a short course of IB and then switch to PO and complete usually 4 to 6 weeks. But yeah, so you don't have to give IB for a long time unless there is something really bad going on there.
I think that's what's misleading for me always, because we'll see, when we only see them in a week for a week in the hospital, it's always so much, seems so much more reassuring than the ones that we end up having for weeks on end for inpatient management. And we have Dr. Coel joining us. Dr. Big just did a little impromptu session on lower back pain and infectious etiologies for the last few minutes.
All right. Well,
welcome.
Thank you. Let me share with you a little bit about back pain and again, kind of walk you through some diagnoses that I think are really important as far as things that we would want to see and commonly in practice, and how we, would want to, again, address it in the clinic setting typically. I don't have any disclosures, but I will thank my colleagues in sports medicine who have kindly shared some slides with me, and I kind of grouped it into my own talk ultimately. But again, just want to thank Dr. King and Dr. Pango for sharing slides with me. My goal today is to get through whatever cases I can. Again, I apologize that my clinic was a little bit of a disaster today. So it's the real world. So I apologize, but I do want to get through a case-based review of common back pain presentations that we might see in the general pediatric setting, and then look at some pearls that may help you identify the diagnosis, and look at some pearls as far as also treatment plans. And then ultimately, what are some red flags that we want to, be aware of as far as back pain. So I usually start with a story that has absolutely nothing to do with back pain, but is just clinically an unusual case. So I have a question for everybody. Does anybody know what this is? I can tell you that it's a scope. It's a scope picture, and you probably won't know necessarily what this is. But what it actually is a turtle. And so I always start with it just to make sure everybody's awake over the lunch hour. So this is one story that I start with. So my friend is an ENT and shared these images with me, obviously HIPAA protected here, that this is a gentleman who had a few too many drinks, a 20-something who had a few too many drinks and was dared by his friends to try to swallow the pet turtle that had died about a week prior that they still had for some reason in a tank. And he did, but it wasn't successful. It got stuck, and she had to, emergently remove it because he was choking. And he did survive. The turtle clearly was no longer alive anyhow. But like I said, if that doesn't wake you up, I don't know what will. So there you have it. Real stories from the medical world. So let me shift gears a little bit and start with some pearls for your exam. They don't have anything to do with turtles, but let me share with you some things to think about. So where I'd start first is with inspection. I'd be looking for things in the back. Obviously, yes, you're going to be looking for skin findings, cafe au lait spots or dimples and so forth, but you're also going to want to look for things like asymmetry that might point you towards something like scoliosis. You might be want to looking for soft tissue swelling that might take you somewhere else, like to a mass. You again want to look for your skin findings that may take you down like a neurofibromatosis diagnosis. Or there can be asymmetry elsewhere, so don't just focus only on the back. Make sure you're looking at extremities. If you can see the picture on the bottom left where there is some muscular atrophy going on in that right leg compared to the left, that might make us worry that something might be impinging on the nerve and causing less activation of the muscle. And so you might be thinking more spinal cord or disc type problem. So we do want to again kind of do a full thorough look over of the whole body and not just the spine. Palpation, again, I don't expect anybody to memorize all of these locations on the spine, but we do want to keep in mind that there are some bony landmarks that may help you all the way from C7 down to S2. And so you do want to look everywhere from neck and back down to the glutes and pushing in different areas looking for tenderness. We want to check our range of motion, and these are just kind of general ranges. We can flex further than we can extend back. We can twist, and then we have our lateral flexion kind of going side to side, and that may help point you in the right direction as far as what kind of pain they're having or what kind of diagnosis. We'll go into that a little bit more. I think this is a helpful slide. This gives you some quick tests you can do to walk you through your neuro exam of your lower extremities. And so your MMT is your manual muscle testing. And so if you have them flex the hip, you're getting L2. If you have them extend at the knee, you're getting L3, 4. If you have them ankle dorsiflex or pull up with their ankle, you're getting L4, 5. You could have them simply just stand on their toes to get S1, and you could simply have them just curl their toes to get S2. So this is kind of a quick Other special tests that we think of when we're doing our exams, we're going to think of things like, hamstring flexibility, and looking at the popliteal angle can give you a little idea of, again, how tight are they? Sometimes people are tight because of pathology. An example might be because they have a disc injury, they've got spasm in their hamstrings and their calves, and so they've lost some range of motion. But they could also just be tight, and chicken or the egg, they could just be tight in their legs, and that's also loading up the back now, giving the spine extra stress. So and the paraspinal muscular. So you want to think about, again, looking at hamstrings. This test is called the slump test. Some people also call it the slouch test. But what we're doing is we're actually testing, it's not actually a hamstring test. So if people are having pain in the hamstrings, that's not actually what we're testing. What we have them do is we have them slouch, and most of our adolescents are really good at this because that's their natural state. So you have them slouch, and then what you're going to have them do, it's the picture of the woman kind of with her hand on the gentleman's neck. What you're going to have them do is extend one leg and kind of slump down their neck. And if they have neural tension, if they have nerve tension, they will often have pain elicited as a burning sensation that can go down their hamstring into their foot, or they might have more intense focal pain in their lower back at the site of where that disc might be impacting the nerve. This is called the stork test. This test isn't the best as far as specificity. It's pretty good for sensitivity, but not great for specificity. But what we're looking at is looking for a test to help us guide to something called spondylolysis, or spondy for short. And what's happening in this picture is the woman sort of back behind the man, just giving him a little guidance or support. But what he's doing is he's standing on one leg and he's extending back. And in doing so, he's loading up the vertebrae in such a way that it can put extra load on an area that's called the pars interarticularis. And we'll go through this later, but it can load up the spine in a way that aggravates the spondy, the area of a stress fracture in the spine. So if they don't hurt on the left, you switch, you have them stand on the right leg and extend back as well. Again, not a perfect test, but helpful, can be helpful for helping us get to the point of saying that this is a spondy. A positive would typically be pain either in the low back or radiating into their glute. So if they have butt pain, that can be an indicator. And then in this test, this can be a good test, like a figure of 4, looking at if you're holding down the pelvis and you kind of get the other leg splayed out like that, that can help you understand a little bit better if they have SI joint pathology, sacroiliac joint pathology. So this puts a little tension on the pelvis and kind of pulls on that SI joint by, again, kind of abducting that hip in a flexed position and externally rotating it. So if that does bother them, that's something to look for in the SI joint. And I would say, just to pop in here, what I will say is if you have questions, you can always flag me down or raise a hand or just turn off your mute and ask, because I certainly don't want to march on if people have questions. The first case I wanted to go over is what I call the case of the broken coat hanger. And you'll see why I kind of called it that. But we have a 13-year-old girl who's a competitive gymnast, and she's level 8. And if you don't know about gymnastics, once they get competitive, goes through levels. And so the higher the level, the more hours per week they're putting in, the more advanced the skills are that they're doing. So she's pretty high, level 8, it goes up to level 10. And so she's practicing 20 hours a week as a 13-year-old. So it's like a part-time job. She's got lower back pain for the last 6 weeks, and it's been gradually progressive, worse when she extends, worse when she twists, and does get a little better with rest. She can't think of anything that's actually happened to her. She didn't fall off the beam or anything like that. It's just that her back pain has kind of snuck up on her and is getting worse. You examine her and find that she's tender over the L4, L5 area focally. It's a focal pain. She's really stiff. She doesn't want to move, very guarded in her lower back, both in flexion and extension. But when you get her into extension, when you arch her back, like this stork test picture that's shown on the slide, she really has severe pain. And she tells you it radiates to her buttock. You also notice that when she walked into the room, she kind of had this really wide-based, kind of guarded stride where she's kind of holding her trunk very stiffly. And then you notice that she's a kind of your classic gymnast. And so she's got what we call a hyperlordotic position where she's really arched deeply in the lower back. And then finally on exam, she's got very tight hamstrings, which wouldn't be consistent with being a gymnast, and more consistent with an injury and something bothering her that's kind of locking up her hamstrings. So you decide to work her up and you get some x-rays. And so we're looking at the x-rays, and you decide to get an AP and a lateral view. My suggestion would also be that you may want to get oblique views, which are sort of sort of halfway in between being in the AP plane and being in that lateral plane. They get sort of a 45-degree plane, and that will give you some information better about this area. Again, the pars interarticularis that we're interested in. And in specific, you may have heard of this term, the Scotty dog collar, if you've ever learned about a spondy before. But what you're looking for on X-ray is going to be a line, a lucency through the pars, and I'll show you on the next slide what that looks like. And why it's called a Scotty dog collar is because the way the bone shape looks on X-ray looks like a dog, and it should be a dog without a collar, but if the dog has a dark collar, that concerns us that that's the fracture. So I'll show you what that looks like. So here's your X-ray, and you might be looking for it. Where is it? So I kind of drew it out for you in my horrible illustrative way, but they're the exact same picture, left and right, but the Scotty dog collar is the break in the bone right here. Whereas if you look at the one above it, it's got his eye, here's his muzzle, here's his ear, but he has a full neck. There's no break in the neck. Whereas here there's a lucency. Do you see that dark spot? And I kind of put a red circle around it for you. That collar should not be there. That is a disruption of the bone. And so what if though you had gotten the x-ray and it was negative? Does that mean she's totally out of the woods and couldn't have this break? Not necessarily. If the x-ray is negative, you want to think about a stage 2 workup, which would be, I would move on to getting an MRI of the lumbar spine. If your exam and your story fits, you've got a gymnast or a cheerleader, somebody who does a lot of back extension as part of their exercise, I would move on to an MRI without contrast. There are other options, but why I choose MRI is because there's no radiation to the pelvic area. There are focal CTs you can do that try to limit radiation, but there's still some. So it isn't quite as sensitive. So you definitely want, well, let me say that it's not quite as specific. So if you want to make sure the radiologist knows what you're aiming for, make sure in the order for the MRI without contrast that you put MRI, lumbar spine without contrast, evaluate for spondy, because they have their own protocols. They'll set up the MRI in such a way as to specifically look for that. And that can help, but it doesn't have the same bony detail as the CT. So if you don't tell the radiologist that, you may miss it, or the radiologist may not read for that. This is what it may look like on MRI. So if you look at the tip of the white arrow, there's this black area here that should not be there. That is the break in the pars. Whereas if you see, this is all one vertebrae, there's a disc above, a disc below, and the bone all comes together. Here, disc above, disc below, and then there's a break. And then you can also notice this disc doesn't look very healthy. It's been flattened and it's dark. It should have some white, some fluid in it. So that also tells you this has been a chronic injury and it's starting to injure the disc as well. Again, as I mentioned, you could do what's called a focal thin cut CT. It gives you very good bony detail and can help us kind of separate things out, but it does have some ionizing radiation. And it's a common debate that we have in sports medicine and or spinal orthopedics about whether we do the MRI or the CT. I think it goes to your preference and your confidence. This is what it would look like on CT. It's very obvious. We're looking kind of top down. Here's the bony part of the vertebra. And then this side is okay. This is a normal joint. And then here it's broken. So again, something to look for. This is just broken on one side. You can have it actually broken on two sides. This is what it would look like bilaterally on a CT. So you can see the breaks here and here, and I kind of put arrows to show you that there's a disruption on both sides. On the side view, what it would look like laterally is here's a disruption right here and down here. This is what a growth plate looks like, so it can be confusing. So those of us who look at these a lot know that this is not a break. These are growth plates in the dorsal spine area, but that is the area where I have the red arrows pointing. Spondylolysis, again, is the name of the diagnosis, and it is a stress-related injury to the ossification center on the neural arch, or also known as pars interarticularis. Give me 1 second, I'm just going to close this door. We're a busy office, I apologize. It's not a crazy common injury, but it actually, to clarify, can be in existence in congenital forms as well. So I think it's important for you to know that 6% of the population can just have it at birth. So you just need to know that that is a possibility, that just because you get an MRI for something else and it mentions a congenital or it mentions spondylolysis, but you have a kid with no pain and has no symptoms, you don't have to treat that. Really, we're talking about a symptomatic one. A symptomatic one that comes in with back pain and you get the imaging and it confirms it, that's a different story. Then we're going to want to talk about how you treat it. It's more common in adolescents than in younger children. So spondy is most common in your hyperextension athletes. So you want to think about your athletes that are gymnasts, cheerleaders, divers, figure skaters. Also think about football linemen. People don't consider that a lot, but they're doing a lot of pushing and arching up when they're colliding against another player, and that puts their back into extension, coming from that crouched stance position. Soccer players, because they lean back and head the ball. Baseball pitchers, as you can see in this picture, or volleyball players, because they do a lot of arching in their roles as well. It tends to be progressive. There is a traumatic form, and that's usually the kind where somebody fell off a horse. I'm talking about, in this situation, we're talking about kind of that chronic insidious onset where it starts quietly and initially it's only pain with that sport activity, but it ultimately progresses to pain at rest, pain with activities of daily living, and they're just noticing it every day. And your tip off, again, your kind of pearl here is that it's going to be pain with back extension. They'll talk a lot about that they can't arch back, and they tend to be really stiff when they move because they don't want to arch back. Classically, again, the gymnast would be like the arrow that says bad on the right, where they have an excessive anterior pelvic tilt, where they get into this hyperlordotic position and it really loads the spine. And a more neutral position is what we're aiming for. On exam, you will find that they're typically very focally tender. So if you have a kid who's sore from guts to gill, in other words, they're sore from, way up at the high end between their shoulder blades and it goes all the way down, it's very unlikely to be a spondy. Spondy, they can often with one finger say, yep, it's right here, and they'll point and they'll tell you exactly where it is. That's very common. And then when you examine them and you palpate, no, yeah, ow, that really hurts. That's kind of a classic spondy. The most common location is going to be low down, so in your L5, and then one step above that at L4. And again, on exam, I tend to do this exam a lot. It's like I tell them it's like doing a little yoga for me. Leave your pelvis down and kind of arch up into that. Is that cobra? I'm not a great at yoga, but that position there is what I have people do to arch back up, and that often will be very positive. They won't go very far before they say it hurts very badly. Here where the back side of this vertebrae doesn't line up. And you're going to see it on a lateral view is where you're going to get it on your x-ray. And that matters because it loads up the bone and loads up the disc and can damage the disc, as you can see in this picture where the disc is really flattened. We grade spondy as far as the spondylolisthesis and how much slippage, and it's really just based on how far it's slipped. And the further it's gone, the more likely it is going to need a surgery to stabilize and repair it. in the early phases, like the grade 1s, for example, typically do not. And what that looks like is, how much there. What happens is we kind of measure how far it's moved in relation to how wide the bone is. So you can see how far it's kind of slipped, and then we take that in relationship to the actual width of the vertebrae itself. And so then you would say, oh, that's about, 20%, it's 25%. Well, if it stays within that 1 to 25%, that is a grade 1. So what does this all mean? So it sounds scary, and I started off with this case just because you've probably seen it, or I should say, they always have that saying, right, that you may not have seen it, but it's seen you. It's probably been in one of your, if you're doing general pediatrics, it probably has been in one of your clinics, and we just didn't see it. The good news is, as bad as that name sounds, spondylolysis and spondylolisthesis, these early forms are treatable, and usually will keep coming back until or see a specialist until the diagnosis is made. And long term, while it can be painful, is not always dangerous. So I don't want you to worry. People hear stress fracture of the spine and go to a really bad place as far as what this might mean for them long term, but can be very treatable. The acute phase, we really try to first shut down their sports participation. We really focus on some pain management. They're pretty lit up early on. And this matters because, again, if we can't get their pain under control, they really can't go very far in physical therapy. So we want to make sure that we get them the rest coupled with some pain control first, so that then once their pain comes down, they can make some progress in physical therapy. And then once their pain has come down, then we can get them into PT. And I usually write on my PT prescription, another pro for you is that I usually write the words flexion-based physical therapy. And I make sure the physical therapy center knows the diagnosis, knows that it's a spondy. Because really, if the origin of this problem was going back into extension, we don't want to load them up, right, with with extension-based activities. We want to really focus on flexion-based physical therapy. So it's going to be a lot of focusing on flexibility, stabilizing the lumbar spine with core strength. There is the possibility of bracing. The evidence for bracing has not proven beneficial as far as healing the spondy, unless it's been an acute one. Again, very separate case if you're talking about somebody who fell off a horse and that happened and it snapped that area of the pars. Bracing can be helpful there. But if we're talking about somebody where this kind of snuck up on them due to repeated overuse, then the bracing hasn't been proven to be effective in the medical literature. However, I think there's what we know, what we see in the literature, and what we know works for our patients. So I think in treating pain is really important. If you have a patient who's miserable and really seems so uncomfortable that you can't get the pain under control with simple rest and maybe, NSAIDs, then I would suggest thinking about a lumbosacral orthosis is what it's called, or an LSO, which stabilizes the lower back and prevents a lot of that flexion, extension, and rotation. The disadvantage of the brace is it's a little cumbersome, and maybe the compliance isn't going to be the best anyhow. So really, those people who are motivated to wear it because of pain probably will, and those people who you think you're just helping by throwing a brace on probably won't wear it anyhow. That's kind of what it looks like. It's kind of a rigid brace, and you can imagine then, like I said, a lot of adolescents won't choose to wear it. The treatment, we're going to keep going in physical therapy and get them stable. They're going to do a lot of core work, really working on balance, like in this picture, and real sport specific things as they move on. But we're not going to let them typically go back until they're pain-free, they've got good motion, good strength, and that in their sport, they're functional. It's one thing to be pain-free with daily life, but it's another thing to be pain-free in gymnastics. That can take a variable amount of time, classically as early as 6 weeks, but can take for some people up to 12 months. I've had some really challenging cases where it took a while. So do I follow up on them? Yeah, I do. I usually like to see them about every 4 weeks. I don't typically need to repeat an MRI or a CT, but if something weird is going on and they're just not making progress like I'd expect, then sure, down, a few months down the road, I would certainly think about it if it's been, 4 to 6 months and it's just not changing. If it's been close to a year, somewhere in that 9 to 12 month mark, they're really not getting better, or if they do have a significant slippage, that spondylolisthesis, more than 50%, that's when we talk about sending them to the orthopedic spine surgeon, because there are some surgical interventions that can be done. And again, out of the scope of this talk, but there are things like lumbar fusions, or you can use screw fixation through the fractures. Obviously, that can really affect somebody's ability to participate well in their sport. So it's not our first line, right? If you fuse the spine, they lose range of motion, and that's going to change what kind of gymnast they're going to be or what kind of baseball pitcher they may be. Typically, the symptoms will resolve, even if the fracture line stays, and this is why I don't typically image again. They may still have a fracture line on imaging, but their pain may go away. And so a lot of times, they heal well, depending on how soon we kind of caught it and how severe it was to begin with. Certainly, it heals better unilaterally than if you have a bilateral spondy, two-sided fracture. And it's better to have an L4 than an L5. An L5 kind of gets beat up more, has a heavier load to carry. So those tend to be a little bit more symptomatic. But one of the things I advise patients, if this comes across your path, you want to give them anticipatory guidance that chronic pain is very common. Surgery is very rare, and you can provide them that reassurance, but chronic pain is common. And typically the anticipatory guidance that I give them is that this is cyclic back pain, that they tend to get well, and then they tend to rest and do well, but it kind of goes around in a cycle where they get better, they do their PT, their symptoms resolve, they go back to their sport, but then something, they keep going back into that extension loading positions. They go see their doctor again, have to go back to PT, and it goes round and round. One of the other things that I let them know too is just that this may get asymptomatic now, but they may hear about it in their body again later, that as they get older, because of the way now the bones are no longer quite in the same position if they've had any slippage, it can be, as in this cartoon here on the left, they can start wearing down the bone and getting a little arthritic. They can compromise the disc, and so it can cause some nerve impingement. So these are people that may later on have arthritis of the lumbar, nerve pain, sciatica, those types of things. So not entirely out of the woods, but not enough for us to pull them from their sports entirely. So certainly if they want to continue, they can. All right, so that is that case. Any questions anybody has on that before we continue on? Good. Okay. I'll take you through another case then. I call this the case of the squished water balloon. And so this is a 13-year-old male. This is actually a true case that I had. He was 13, male football player. Uncle thought he would get him trained up on how to weight lift. And so he worked him up to doing a 250-pound bar with squatting. So a huge amount of weight on his back. This kid said that he had this sudden acute pop in his back and immediate onset of pain and burning down his leg. The pain starts in his back, but goes all the way down his butt, and then down his hamstring, and even down to his foot. And on exam, what you see with him is this guy doesn't want to move his back, really bad inflection, tender over that L5, S1 disc space area. Kind of, you can feel the bone, and then you pop into the space, and hurts with his straight leg raise, and also hurts with a test called crossed straight leg raise, which I will go over with you. And then you notice that he's got some sensory changes all the way down his right leg into his lateral thigh and lateral lower leg. The crossed straight leg test, what it's doing is actually testing, you're lifting the unaffected side. So if somebody has left leg pain, you're lifting the right leg. And in lifting the right leg, you're increasing sciatica in the left leg, the one that was already symptomatic. And what's happening is, again, because of the impingement on the nerve from a herniated disc, it's affecting, lifting one leg affects the nerve on the other side. And if you have a positive crossed straight leg test, you have about a 97% likelihood of a herniated disc. And it typically is an indicator of potentially a poor response to treatment conservatively, meaning just with the physical therapy. So on workup, you're going to do an X-ray, and classic findings on an X-ray would be loss of disc height space. So if you look at where this red circle is, you can see compared to the other vertebrae, the space in between is nice and juicy on the other ones, and then really thin here. And then on the MRI, you can see where this red arrow is pointing. You can see the disc is extruded. It really does look like that. That is what you can see, the loss of the disc height compared to the other discs. And you can see it out into the spinal canal. So that's a herniated lumbar disc. You can try pain control with NSAIDs. We start talking about rest and activity modification, physical therapy again, and Pilates is really advocated for because they do a lot with core stability. If they fail with that, then we're going to be looking at spine orthopedic surgeon referral and possibly physiatry referral. If they're not interested in surgery, one of the things they could think about are there are different types of injections to consider. I'll go to the next case. This has nothing to do with what I opened. So to be clear, this is not about swallowing turtles, but this is the case of similar but different. So, you know, it seems similar, a turtle and a tortoise, but they don't. One's in the water and one's on the land. So you have a 15-year-old male. He's into MMA, so he's been doing some mixed martial arts training, and he went to twist to block, and he suddenly felt pain in his lower back, and it's located in the right lower back, but it kind of radiates to the middle and sometimes to the left lower back as well. On exam, he's kind of like this, right where that kind of red hot look is. That's where he's putting his hand. He's got stiff guarded range of case I just presented. And his pain is worse though in every direction he moves. It hurts with flexion, it hurts with extension, it hurts with rotation. He just doesn't want to move his back. Straight leg raise hurts. It's not in the leg, however, it hurts in his low back. When you do the cross leg test, right? So you lift one leg, he doesn't get pain down the other leg. When you lift the other leg, he doesn't get pain in the other leg. So he has a negative cross straight leg test. But he is very tender over the right lumbar soft tissues, mainly laterally, so not as much a midline exam. He doesn't hurt over the disc spaces, he hurts over the soft tissues. And he has a normal neuro exam, no sensory changes. So while it seemed initially when he walked in the door very similar to the case before this with the disc injury, when you really start breaking it down on exam, different findings, no focal spine findings, no neurologic findings. So this is a lumbar strain. And this is kind of, again, classic that it's usually over that sort of paraspinal kind of lower back. The muscle that's commonly injured is called quadratus lumborum, or QL, you'll hear about. And initially it'll be very, you know, in the acute phase, it's going to be very persistent. It hurts all the time. But then as they start to heal, while it's still going on, it will be more intermittent. It won't be as constant. You can hold off on x-ray. You don't have to x-ray this. In fact, the recommendations are not to x-ray it until you do a conservative trial of physical therapy. And that will help, you know, minimize radiation and also for cost effectiveness. And in this case, MRI is not indicated. So not all back pain needs x-rays or MRIs. It is absolutely okay to do a conservative trial first of some rest or activity modification. And to be clear, I want to be clear about rest. Bed rest is not what we're looking for. We're looking for relative rest. We're looking for people to still go to school, still go for walks, but obviously they're not playing football, let's say. And then again, the treatment for somebody with a lumbar strain, we're going to get them into physical therapy, maybe again, some Pilates, look at taking NSAIDs, they're really sore, keeping up with some light exercise. We know movement is better than no movement. And then I do check up on them usually in about 4 to 6 weeks, just to see how they're doing and make sure they're making progress. They may not be 100%. And I always tell them that I'm not looking for perfection at 4 to 6 weeks. I'm looking for better. On our way to better. And again, this kind of goes with what I had mentioned before. Really, there is a push now for exercise as medicine. It's better to move than not to move. And there's sort of this kind of vicious cycle, so to speak, of when they don't move, their muscles get more stiff and weak. That feeds the chain. In addition, mentally, it's not good for us not to move, and that creates more depression and anxiety. So we do want people moving and getting out, going to school, socializing, light exercise. So I know in the interest of time, we've got 5 minutes, so hopefully we'll just get through this one last case. So this is the case of the COVID culprit, and this is very relevant. So I want to get through this case because it's not about COVID. It's about what we all saw after COVID, which is we've got a 12-year-old female. She's had 2 months of neck and back and lower back pain. It goes to her arm. She complains about radiating arm pain. There was no history of trauma. During COVID, she was doing a lot of online distance learning. And I think now, even without COVID, a lot of kids in particular have gotten really pretty fascinated with video gaming, a lot of screen time. So not doing any sports. She's been mainly sedentary, or a lot less active than she used to be. And I hear this story a lot. I'm sure you guys do too. I used to play soccer. I don't anymore, that kind of a thing. And so on exam, you might see that she looks like the person on the left, where she's kind of rounded shoulders, and she's got that anterior pelvic tilt, that kind of lordotic position of her lower spine, really rounded in the thoracic spine. I'm saying that and now trying to straighten myself out because I know that's how I've been for the last 30 minutes, but it's very common for all of us. And if you look on the left picture, you can see that her head is kind of forward tilted and kind of displaced over her trunk anteriorly, so she's off a little bit. And really what we're going for is more of an inline posture. So there's actually a name for this. It's called upper cross syndrome if it's in the upper body, lower cross syndrome if it's in the kind of pelvic, kind of lumbar and pelvic area. This really has to do a lot with our time that we're spending and the poor ergonomics we have using our laptops and our tablets. So much of what we do is in front of us now. We're doing this with our phones, we're doing this with our tablets, we're doing this with our typing, right? That all of us are probably victims to this as well. And it leads to poor posture due to tightness as well as weakness. So that's where the cross comes in, that some muscles are tight and some muscles have become weak. And so our necks, for example, become weak and our upper traps become tight, and it kind of pulls us forward, right? See a lot of nodding. And then same goes for our pecs. Our pecs become tight, and our traps and our serratus, our lower traps and our serratus become weak, and that kind of arches us as well. And the same phenomenon kind of happens down in the pelvic area. This is sort of our culprit, right? That this looks like any one of us after work, or working on the weekend. You might be at home sitting like this. And laptops are a huge part of the problem because the screen is attached to the keyboard. And so we're kind of forced to slouch down in order to maintain a position to keep typing. And so, again, ergonomics really matter. This is a slide, again, showing what changes could be made, looking at the posture of the person, the way she's seated. And I would argue also perhaps possibly elevating the screen, that your eyes should really fall at a line that's 2/3 from the bottom of your screen. And so, if your screen is too low, you tend to slouch to be kind of looking at the center of the screen, but really we want to be more upright. So I would argue the one mistake in this picture is I would have put a monitor riser for that computer to bring it up a little higher so that it's easier for her to stay in an upright posture. But the pelvic, basically kind of 90-90-90 is what we talk about. The ankles are at 90 degrees to the floor, the knee is about 90 degrees, a little over, and again, the pelvis is about 90 degrees. So it holds you in a better position. There's a name for it now. It's called texting neck, which is real. So anterior head syndrome is the other medical term, but we all are culprits again with this as well, are victims of this, but it kind of crunches us down. But don't worry, not all hope is lost. I have some suggestions, and I think this next slide is very helpful. These are some stretches that any one of us could do during our workday, any of our students could do at school. The one on the left of the woman in the white sweater here with these different phases is actually part of a Pilates technique that can be done that works really well. But again, we're not looking to duck our chin down and create 30 chins. We're looking to go straight back and activate the muscles, keeping our head in the same proper posture. You know, looking to stretch pectoralis, looking to stretch our serratus and lower pecs by doing these kind of wall stretches. Again, working on the neck flexors and kind of pulling back, getting our traps stretched out. These are all things that are easy enough for any one of us to do for 30 seconds that can make a big difference and kind of reset. So, you know, in the interest of time, I know that we got a late start, so I apologize. But in the interest of time, I'm going to stop there and open it to any questions. But if I had to give you any pointers, this one slide can make a difference in your own life. So.
Thank you,
Thank you
Dr.
so much,
Coel.
Dr. Coel.
You're welcome. I again apologize for the late start.
No, not at all. That it gave us ample opportunity to catch up a little bit ahead of time. And I was certainly one of those people nodding along, especially through those last slides. We'll just go through the post-session questions and give our participants a chance to
I'm not sure I got to all of them. I have to see if I was able to
answer these for, oh yeah, and we'll let you take a look and see if we actually went through all of them.
We didn't, but I can kind of get you to them. Let's see. And I'd be happy to come back and give the second half some other time. I apologize because I did have some other cases I, you know, could definitely help with, because they are things that you will see commonly in the clinic.
Yeah, that could be great, actually. I see, especially because I see you do have a good amount of cases still left.
Yeah, I apologize, like I said.
Not at all. Not at all. We'll just see how far people get this time around with these questions. And then we'll give people another minute and then give you a chance to give us the answers.
I'll help you along.
Oh, you know what? It's because you're accidentally co-host. Summer, do you mind changing the co-host status for Dr. Oh, thank you. You can change it for me as well, but I actually meant for Dr. Renata.
Sorry, Dr. Coel, what are you, you need to withdraw co-host?
What do I need to do?
No, it was for Dr. Renata because she's not actually able to answer the questions.
Okay. Me too. Sorry about that.
No, you're fine. Thank you. Oh yeah, Summer, is there any way to send the quiz or pass it along, I guess?
Renata, can you access it now? No, okay, I'll email it to you.
You've just kind of become a part of the Team Pete's Echo Hawaii crew. Sorry. it's kind of like, it's the award for always being here and joining first. Okay, in that case, shall we go over?
Sure. Do you want me to go over the result or the answers?
Yeah, I think that'd be good.
So the first question was actually kind of a tricky question because the question was true or false, spondylolysis or stress injury of the pars interarticularis is more common in athletes who do a lot of forward flexion. Forward flexion is actually how we treat it with the rehab. It's more common in athletes who extend. And so it's athletes, if you think about gymnasts, how they finish, think about it that way, that's extension. They do a lot of back bending and arching and so forth when they're on the beam and the floor. And that's your baseball pitcher who winds up in extension, your volleyball player who winds up to hit the ball. So it was actually, the correct answer is actually false. The next one was choose the one true statement below. And the correct answer was that physical therapy and Pilates are good first choices for a lumbar strain. To go over quickly the other answer options, with lumbar strain patients, the mainstay of treatment is bed rest. As I said, exercise is medicine. We are not big fans of bed rest. When evaluating a suspected lumbar strain, x-rays and MRI are always indicated. And as I had mentioned, in fact, both between the cost savings and the radiation and so forth, we try to limit those and start first conservative measures. And the cross straight leg test assesses for strain of the lumbar paraspinal musculature. And again, that was a nerve test, a neural test to check for disc injury, a herniated lumbar disc. The third question was a true false. Laboratory tests such as CBC, CRP, sed rate should be attained if infection of the spine is suspected, such as discitis or osteomyelitis. And yes, that is true. Typically, if you have kind of a clinical case, and again, I apologize, I didn't get there, but you're ahead of the game if I give this talk in the future. But the answer is true. We do want to do those typically if we suspect, have a high suspicion for that. And then lastly, what are our red flags for pediatric back pain? So red flags for pediatric back pain that warrant urgent or emergent medical evaluation include all of the following except. And so the pain only with sports activity is not classically a red flag, right? We worry more about somebody who's awaking at night with pain. We worry about somebody who's having bowel or bladder dysfunction. We worry about somebody who's having any kind of radicular pain down their leg or some kind of neurologic deficit. But somebody only having pain with sports makes me think of maybe a lumbar strain. Even a disc injury would hurt at other times of the day. But if they're only having pain with their sport, that's not as much a red flag. Questions on any of that? I did put up, I don't know if let's see, does this move? There you go. Move it up here. But my contact information is there, both my office and my cell, as well as my email. I'm always happy to answer questions on anything. Doesn't have to be about pediatric back pain. It could be anything that might be concerning. I'm certainly happy to answer questions.
Thank you so much, Dr. Coel. We really, really appreciate you making the time and making it, even with the crazy busy schedule you guys hold, and for sharing all of these interesting cases and your contact information, which is always very appreciated as well, because you never do know when questions might come up.
Yeah, and honestly, I look at it as a two-way street, that if I see one of your patients, I want to be able to get back to you if I have a question, or if I think there's something specific that might enhance your relationship with the patient. I want to let you know about it. So I really appreciate communication with me as well. Before I see them, or if you have a question about what I did, I'm always happy to hear from you, as well as if you just have questions. I would love to help you facilitate seeing your patients on your own and just keep it in your office in the medical home. Happy to do that as well.
Thank you so very much. We really definitely appreciate that. And really, honestly, that's ultimately really what Pediatric Echo is all about. So it's so good to hear that. Thank you, everyone. Again, thank you so much for staying longer. I hope you all were able to take some nice little nuggets into your afternoon. And we'll definitely touch base also about potentially completing this talk at a later time with the additional cases you had. And in the meantime, we'll see everyone back in 2 weeks. Dr. Erica Noel over on Kauai at Wilcox is going to be presenting. We're still ironing out her topic, but we'll send you the flyer as always. So thank you, everyone. Have a great rest of your day.
Thank you.
Mahalo. Thank you, Dr. Cole.
Thank you.
Bye.
You're welcome. Thank you.